Hi, I'm Dr. John Martin with Ivy Family Health Updates, and I'm here with my sister, Dr. Catherine Martin, my brother, Dr. Edward Martin, and our special guest is Dr. Sal Fusaro, who's a board-certified psychiatrist, and he's here today to talk to us about depression, explain a little bit about what it is, how do we diagnose it, and how do we treat it. Sal, nice to have you here. Thank you for coming in.
Thank you, John, for having me. Depression is common illness in the population, so it is really an important thing to talk about. Presenting symptoms to meet criteria, of course, one is you feel depressed, but more importantly is the loss of interest that people experience in their everyday life, from things like watching their favorite television program to reading a newspaper. All of a sudden, they don't have interest in that anymore. And it's part of the nature of depression to begin to withdraw from life and activity. So that is a significant symptom. And often, I will see a person who says, I don't feel terribly depressed, but I have no interest in the things that once gave me pleasure. The other significant symptoms, of course, of depression are loss of concentration, decreased appetite, difficulty with sleep, falling asleep, staying asleep.
Sal, at what age do you typically see sort of the first signs of depression?
That's a very good question. It can happen really at any age during the life cycle. We do see it in children. Typical age of onset is late adolescence and early adulthood, and we see varying degrees of severity. Someone in late adolescence and early adulthood may have just like mild symptoms and they don't present for treatment. 5 years later, they may present with a more serious episode that brings them to treatment.
Now, who usually makes the diagnosis of depression?
Well, that too is a really terrific question. Most people present with depressive symptoms to their primary care physician, pediatrician, family physician, or any one of a number of specialists, because they often have somatic symptoms. What do I mean by that? People have chronic headache, chronic fatigue, they may have chest pain, they may have difficulty breathing, so psychiatrists tend not to be the first person to see someone who's depressed unless they present with very severe symptoms.
Sal, I have a couple of questions. One of the symptoms you said was sort of weight loss, but certainly a lot of people who are heavy say, I eat when I'm depressed. Is it just that they eat and that makes them depressed because they get heavy, or are they, you know what I'm saying?
Sure. Actually, weight loss or loss of appetite is the most frequent symptom of depression, but you can see increased appetite in people with depression, so then they will have weight gain. We tend to think that may be a different kind of depression and may require a different kind of treatment, but essentially, we're going to start at the same point, even with people who have an increased appetite with the use of an antidepressant medication.
And could you just go over some of the medications that people are using now? I think there are a lot out there, so it's...
Yeah, we have, since probably the late 80s, we have the advent of the serotonin reuptake inhibitors, and then a second group, which are the combined serotonin and norepinephrine reuptake inhibitors. And the serotonin drugs were the first to come on the market, and Prozac, of course, was the leading one. These medications were a significant leap forward in the treatment of depression, not because they were more effective necessarily than the early ones, but their side effect profiles were really much better. They're much better tolerated by and large. Early treatment, you get some headache, you get some nausea, most of which is tolerable. Very few people discontinue. So these are really very effective, well-tolerated drugs.
Sal, could you comment a little bit on the side effects? There are two in particular that a lot of my patients are concerned about. And one is weight gain, and the other that's a real problem is the sexual side effects.
Sure, be happy to. Both of those are long-term side effects of these drugs, or at least can be. Now, statistics show about 50% of people will have sexual dysfunction as a side effect. So that means the other half, have no side effects. So we are looking at a significant side effect in terms of decreased libido and delayed ability to achieve orgasm in men and women. Sometimes lowering the dose will help. Sometimes switching to a different agent within the group may help.
Will that ever just go away with time, or?
Yes, actually, that is the third thing. Some
Okay,
people
sorry.
accommodate. No. Yeah, very valid point. You accommodate to it over time, and so you have return. The one side effect, loss of libido, tends to be the most resistant. But as we typically say, in psychiatry, the largest sex organ in the body is the brain. So, okay, you don't have it the spontaneous interest, but as human beings, we can think and therefore create the interest.
Okay. And so, in terms of social stigma, you go into CVS or another drugstore, and you go up to the counter, and they go, "Your Prozac's ready," So, how are people dealing with that now? Is it more accepted that are a lot of people using these medications, and they've so they're more willing to take them?
I think generally that's true, and I have patients who are advocates for mental health and for destigmatizing depression. So they're the people who will go into CVS or Walgreens and say, "Can I have my Paxil? Can I have my Prozac?" Because they want it known that this is what I do and it's perfectly acceptable. And you've had celebrities, certainly, who've come forward who have added to the destigmatization of depression, and that has been very important.
Just a comment in my own practice, I see a lot of women as an endocrinologist with sort of mild mood disorders who would really benefit from the SSRIs. I mean, they're such an effective class of drugs, but what holds them back is partly the social stigma, but the other perception they have is that these drugs will change their personality. And so, I have to reassure them that it's not going to change your personality. It's going to make you feel like you on a good day. And once you can sort of get past that and past the social stigma, it's really, the improvement in quality of life is just, tremendous. I mean, they're such effective drugs.
No, that's very true, and I think that's really a very good point. The more you can, tell people this isn't going to alter who they are. Right. It may bring them back to who they have been, which actually is, that's the great thing about treatment. People who don't feel like themselves are now back to themselves. Their sense of humor is back.
Right.
That's an excellent point. And, talking to patients and explaining that to them, is a very important part of treatment.
Now, at times it seems in an older population that family, friends, and sometimes even the patient may attribute the depressive symptoms to old age and so may not seek treatment. Is that something you've seen and experienced?
Yes, I have, and it's unfortunately a terrible fallacy. Older people get depressed. As I mentioned earlier on, this is an illness that can strike anywhere during the life cycle. So you can have someone who's never had a depressive episode, reaches their senior years, and they are now depressed. Treating them makes a huge difference, and it sort of goes back to Kathy's point. You get return of quality of life, and that is, usually an important factor for both the person and their family.
Can you just say a quick word, too, as a therapist, therapy versus drugs? I'm sure there are some people who don't want to take the medication. Is the therapy going to be enough for these people, or are they, can you try that first, and then if that doesn't work, put them on the medications? Or
you certainly can, and cognitive therapy in well-controlled studies has been shown to be as effective as medication. Other studies show that the combination of medication and psychotherapy are really, that's the best treatment. That's optimal. Certainly psychotherapy should be a part of treatment, and a doctor's responsibility to convince a patient, yeah, medications will help. Talking to someone will help as well.
All right. Well, Sal, thank you very much. Very
My
informative.
pleasure.
All right.
Thank
Thank
you.
you.
Thanks for having me.